So, uh, first of all, hello to my colleagues and friends from all over the world. If you're listening to this webinar, of course, it's a great honor for me to share some information, to share some cases, and especially about aligner treatment, and especially about cases where we need bodily movement, root movement, like distalization or space closure, because I personally think that aligners are the future of orthodontic treatment. I don't think that we have many brackets in 20 or 30 years that we are bonding. So aligners are for sure the future. They're getting better and better. The ClinCheck is getting better and better. But we do see problems if it comes to bodily movement, and I will speak about this. So again, I'm sitting in Düsseldorf. I'm there at the university, Department of Orthodontics, and this is where I'm right now. And again, hope to see you soon personally at a congress after the Corona crisis. Düsseldorf is a beautiful city. And again, if we are able to travel again, you are very welcome to visit us here at the university. It's a lovely city. It's just 10 minutes to get from the airport to the city center. So very easy, not so much traffic. So please visit us after the Corona crisis. Uh, as mentioned, I think aligners are the future. We have a couple of advantages. It's more aesthetic, but additionally, we see a low risk of developing caries, which is a big advantage, especially for our younger patients. So two big advantages. And last but not least, the third big advantage, it makes fun from my point of view. How about efficacy? If we have a look at the literature, we can distalize maybe 1.5 millimeters. Um, that's another study where some heavy users of aligners distalized even more than 2 millimeters. I don't know how much this is a bodily distalization, but at least the crown was moved up to 1 or 2 millimeters. Uh, there are some heavy aligner users, they think I can do everything with aligners. The question is this really the truth? And we have to discuss how many aligners and refinements are needed if you want to do bodily movement. The molars are tipping. You take another impression or do another scan, it takes so many years. So most of my patients, they are motivated for 1 year, maybe a little bit more, but after 1 year, they want to get finished. So how much time is needed? How much elastics are needed? If you want to distalize with the sequential distalization procedure, it takes so much time and you need so much compliance in terms of elastics. Yeah? And predictable bodily movement, this is a problem. How about class 2 elastics, especially if you have asymmetric situations? You may get an asymmetry in the lower arch if you use class 2 elastics. And last but not least, if you use T's for anchorage, you may see root resorption as well. This is an open bite case from our study group, and the doctor wanted to intrude molars up and down the elastics were applied. And please have a look at the roots of the central incisors. This is before and after up and down elastics, it looked like this. So severe root resorption. So maybe from time to time, it's better to use not teeth as anchors, but maybe mini screws. They may fail. In the palate, the failure rate is very low, but you never see a mini implant resorption or something like this. So, what are the major problems if it comes to aligner treatment? Bodily movement, as mentioned. Yeah, in the transverse dimension, it's impossible to expand bodily. The teeth are going to move. Um, and next to expansion, you see two papers. It is distalization and space closure. Space closure may be more than 1.5 or 2 millimeters. You can close small spaces. This is not an issue. But if you want to close spaces of maybe 5, 6, 7, 8 millimeters, this is impossible with aligners only because you see tipping in 9 out of 10 cases. Maybe in 1 out of 10 cases, it works. Yeah, you see lectures from heavy aligner users where they are closing spaces. It works in some cases, but how predictable is this? This is a question. I'd like to show you two cases treated from another orthodontist by another orthodontist. First case, adult patient with a severe protrusion of the incisors in the upper arch. The doctor wanted to take out the first bicuspid in the first quadrant and the first molar in the second bicuspid. And then it was time for space closure, and you see what happened. Severe tipping of the teeth, and this is what we usually see. He wanted to correct this afterwards with brackets, because if you try this with aligners, you will see in many cases severe tipping. Another case, a second case, treated in private orthodontic office, class 2 div 2, some crowding in the upper arch. A doctor wanted to take out two bicuspids and wanted to